Video, we have discussed ICL surgery-related glaucoma and cataract, but there are other potentially blinding complications of ICL surgery we need to discuss. Even though the risk of these complications is extremely low, they can occur. And it is important for patients to know the risk so that they can make the right decision. So for today's video, we'll discuss ICL surgery-related endophthalmitis, endothelial cell loss, and retinal detachment. Let's get into it. Hi everyone, welcome to a new video. This channel dedicates to providing you with the most comprehensive and up-to-date eye health information. If you're new here, consider subscribing. Thank you for your support. This video is also a part of the complete ICL surgery series, so if you want to learn more about ICL surgery, you can check out the playlist or leave a comment in the comment section below and I will answer it to the best of my ability. The first complication we're discussing today is corneal endothelial cell loss. The human cornea is a transparent avascular tissue that helps to reflect light on the retina, accounting for around 2/3 of the eye's total optical power. The cornea is arranged into 5 well-organized layers, and each layer plays a unique role in maintaining the transparency and the viability of the tissue. These layers include the epithelial cell layer, Bowman's layer, the stroma, descemet membrane, and the endothelial cell layer. The endothelial cell layer is located beneath the descemet layer and is the innermost layer of the cornea. The endothelial cells have 2 roles, barrier function and pump function. These cells contain proteins that allow nutrients to enter the corneal stroma from the anterior chamber while osmotically drawing water and ions from the stroma into the aqueous humor. The endothelial cells are critical in maintaining corneal thickness and transparency. Average corneal endothelial cell density at birth ranges between 400 and 500 cells per millimeter square. The CED rapidly declines during childhood and adolescence and reaches around 3,000 cells per millimeter square in early adulthood. From there on, the CED continues to decline with aging at a rate of 0.3 to 0.6% per year, dropping to around 2,000 to 2,500 cells at age 60. The most probable reason for this decline could be the role of the apoptosis and/or necrosis caused by light-induced oxidative damage. Other factors such as trauma, ocular surgeries, glaucoma, infections, and diabetes mellitus also accelerate the loss of corneal endothelial cells. Endothelial cell damage is often inevitable in ICL surgery. The incision made to insert the ICL, instruments-related trauma, and the irrigation solution turbulence can all damage the endothelial cell. Not only will ICL induce instantaneous damage to endothelial cells, but it will also speed up the loss of CED every year after surgery. The reason for the accelerated loss is still unclear. Still, ophthalmologists in the Eye and ENT Hospital of Fudan University, Shanghai, China, speculate that the presence of the ICL might have altered the circulation of aqueous humor, which results in poor metabolism of the corneal endothelial cells. Unfortunately, the endothelial cells cannot proliferate, unlike the corneal epithelial cells, which have strong self-renewing capacities. Cell damage caused by different pathologies stimulate the remaining endothelial cells to enlarge and migrate to cover the defects. The critical number of CED to maintain corneal transparency is 500 cells per millimeter square, and any further deterioration in cell count leads to corneal decompensation. Due to insufficient corneal cell density, fluids build up in the cornea, leading to corneal edema. The patient may be asymptomatic at first, but the cornea swells and becomes opaque as the edema progresses. There may be glare or blurred vision caused by faults in descemet membrane and increased stromal thickness. Eventually, visual acuity decreases alongside discomfort or even severe pain. Other complications such as corneal vascularization, infection, and scarring would likely occur. So yes, excessively low CED can cause blindness, and we definitely don't want that to happen with ICL surgery. And STAR Surgical is aware of this problem, and the company recommends a minimum endothelial cell density requirement for ICL surgery. STAR Surgical is highly meticulous with the CED requirements, and most doctors would not require you to have 3,800 cells per millimeter square in your early 20s, but most of them will require at least 2,000 cells per millimeter square, or maybe 2,500 cells if you are young. STAR Surgical also recommends an anterior chamber depth exceeding 3 mm. A shallow anterior chamber means the doctor has less space to work with, and hence an increased risk of instrument-related trauma to the endothelial cells. Most doctors would lower that number to 2.8 mm, but 2.8 mm is the absolute minimum for you to have ICL surgery. If you have an ACD between 2.8 mm to 3, then make sure your surgery is done by a truly experienced surgeon to minimize endothelial cell damage. In the earlier decades, other brands of the intraocular lenses were implanted to the anterior chamber, which is associated with severe endothelial cell loss, which ultimately requires corneal endothelial transplantation. Fortunately, the ICL is implanted in the eye's posterior chamber, which has a far lower risk of causing significant endothelial cell damage. The newer models of ICL also lead to a less rate of CAD loss per year due to the improved flow of the aqueous humor. In this study published in 2018, the author analyzed 21 studies, including data of 1,476 eyes with a weighted average follow-up of 14.7 months. The mean endothelial cell loss is 2.6%. This percentage reduction includes both the acute effect of surgery and any chronic loss during the follow-up period. Fortunately, the reduction is in an acceptable range, with no patients having a larger than 30% decrease in CAD. The rate of loss of CAD will also decrease as the years goes by, so at least theoretically, as long as your surgery is uneventful, your CAD should not drop below the critical level as you age. But again, because there is insufficient data on the long-term effect of ICL surgery, especially the V4C model, on the endothelial cells, patients should be notified of the risk before surgery. Because you will have a permanent implant inside your eye, you should follow up with the eye doctor ideally once a year to monitor endothelial cell density. Just in case if something happens, your doctor can explant the ICL to prevent further damage to the endothelium, which might require a corneal transplant. So the next complication we will discuss is endophthalmitis, or intraocular infections. All surgery have a risk for infection. However, compared to laser eye surgeries in which the worst infection you can get is keratitis, ICL surgery is an intraocular surgery, meaning that the doctor has to cut open the eye to place the lens. Infections from such surgery will be intraocular. Endophthalmitis, although extremely rare, is probably the most devastating complication of intraocular surgery and potentially lead to severe vision loss. The visual prognosis is largely variable depending on the virulence of the pathogens and how quickly you get it treated. In the vast majority of cases, unfortunately, the visual outcome is usually not great and many patients sustain severe visual loss. Corrected distance visual acuity of less than 20 to 100, which is enough of being classified as legally blind. In the worst case, the doctor might have to remove your globe if infections can be controlled. So yes, having endophthalmitis after ICL surgery is truly unfortunate. You get the surgery to improve your quality of life, and the last thing that you want to do is to make it harder. However, be rest assured, overall, endophthalmitis after ICL surgery is extremely rare. This is an article published in the Journal of Cataract and Refractive Surgery in 2009, where the authors contacted 234 surgeons and asked for their total ICL implant and cases of endophthalmitis between 1998 to 2006. Out of the 234 surgeons invited to participate, 95 answered the first survey, a 40% response rate. The 95 respondents had implanted 17,954 ICLs during the study period and reported 3 cases of endophthalmitis. This means approximately 1 case of endophthalmitis per 6,000 implantations. This study was done quite a while ago, and due to the advancement in the surgical techniques, the incidence of endophthalmitis after ICL surgery nowadays is probably even lower. So, be rest assured. Prevention is always better than cure. So how can you prevent endophthalmitis from happening? So what you can do on your side is to follow your doctor's instructions. Period. Doctors will let you put an antibiotic eye drop the day before your surgery to kill any bacteria that might be present on your ocular surface. After surgery, doctors will instruct you to use antibiotic eye drops 4 times a day, starting on the same day after surgery. You should also refrain from touching the eyes and sleep with CPACs for at least a week. You need to follow this protocol so that you won't get any germs inside your eyes. This should be pretty self-explanatory, but to be brutally honest, many people don't abide by the rule altogether. So please listen to your doctor and follow his instructions. So what if the worst happens? You actually got endophthalmitis after Icl surgery. Endophthalmitis symptoms usually begin a few days after the procedure, including sharp eye pain, red eyes, white or yellow pus discharge from the eye, and decrease of blurred vision. If you're noticing these symptoms, contact your ophthalmologist immediately. Your ophthalmologist will perform several tests to diagnose your symptoms. They will look at your eyes and test your vision to decide the best treatment. Intraocular administration of antibiotics is considered a fundamental step in managing endophthalmitis. Initially, a broad-spectrum combination of antibiotics such as vancomycin and ceftazidime or vancomycin and amikacin is injected intravitreously as the first and second-line therapy. In a fungal infection, amphotericin B, miconazole, voriconazole are the drugs of choice. Steroid medications will also be given to minimize inflammation. Doctors will also likely perform a test called an aqueous vitreous tap. This test involves using a tiny needle to take some fluid out of your eyeball. The fluid is then sent to a laboratory to test what pathogen is causing the infection so that doctors can make up an antibiotic regimen specific for that bacteria. If the infection is severe, for example, your vision is reduced to hand motion or less, and there are dense infiltrate in the vitreous cavity, doctors will perform an emergency vitrectomy to suck out the infected vitreous humor. The ICL will also likely be expanded because it can serve as a potential reservoir. In the next few months, medications will be administered frequently, and you will need regular screening for bleeding, retinal detachment, and cataract that could develop after a vitrectomy. So in short, the quicker you get it treated, the better the prognosis, but no matter what, hopefully, it will happen to none of us. The last potentially blinding complication of Icl surgery is retinal detachment. Now, should I say complication? So theoretically, any intraocular surgery can increase the risk of retinal detachment, and Icl surgery is one of them. Researchers have been comparing Icl surgery with cataract surgery. Cataract surgery is a well-recognized risk factor for RRD. The posterior of the crystalline lens is more bulged out, which acts as a barrier and prevents excessive vibration of the vitreous humor. Removal of the crystalline lens will lead to anterior displacement of the vitreous humor and significantly increase the risk of posterior vitreous detachment. PVD and excessive rotation of vitreous humor will tug on the retina and increase regiment-target retinal detachment risk. But for Icl surgery, we are really not touching the crystalline lens, so theoretically, the impact on the vitreous humor should be minimal at most. Posterior vitreous detachment and tugging on the retina are the leading causes of regiment-target retinal detachment. Although there are cases of RRD reported after ICL, they are very rare and make it very challenging to examine the possible effect of the ICL on the posterior segment of the eye. There has been no definitive proof of the causal link between the ICL procedures and vitreal retinal complications. So for now, it is safe to say that the retinal detachment post-ICL has to do with the patient's prescription and not the surgery itself. The candidates of Icl surgery usually have unusually high prescriptions, and myopia is a recognized predisposing risk factor for vitreous retinal complication. This study was published on NCBI in 2013, where researchers studied 617 eyes implanted with ICL from 2006 to 2010, and the mean preoperative surgical equivalent is negative 9.73 diopter, while the highest is negative 23. 2 eyes of 2 patients developed regiment-target retinal detachment. The first of the right eye of a male aged 25 years old with negative 12 diopter for an unknown cause. And the second was the right eye of a female aged 24 years with very high myopia due to trauma. This makes a 0.32% overall risk of retinal detachment post-ICL. The risk of RRD and otherwise healthy eye is less than 1 in 10,000 per year, and in high myopic eyes, the risk ratio is 1 to 3 in 1,000. So at least theoretically, Icl surgery does not appear to further increase the risk of retinal detachment. Because there are really no reliable resources on the relationship between Icl surgery and vitreal retinal complications, I guess you shouldn't be too stressed out about it. However, if you are extremely nearsighted before Icl surgery, then definitely get a routine eye exam post-surgery to check for holes, tears, and degeneration of the retina, which could progress to detachment. So before I end this video, I would like to comment on Icl surgery. I went online and saw many advertisements of Icl surgery describing the procedure as reversible, no corneal damages. This is true. Icl surgery is indeed reversible to some extent, and it induces minimal corneal higher order aberrations. But the truth is this: laser eye surgeries such as LASIK are extraocular surgeries and can cause dry eyes, epithelial ingrowths, poor night vision, and regression. Though these complications can significantly affect one's life, they are usually not blinding, at the very least. Icl surgery is an intraocular surgery, so it can damage the delicate structure inside the eye and cause potentially blinding visual complications. So in other words, ICL is a higher risk, higher reward investment. Most importantly, it is a procedure more heavily influenced by human factor, after all. So ICL surgery is not exactly as reversible, no corneal damage as advertised by medical institutions. In truth, ICL surgery requires more caution and awareness. So this is pretty much it for today's video. I've made 5 videos on ICL surgery, and they do an excellent job educating you on what ICL surgery is, its advantages, benefits, and risks. If you think I did a good job, type 1 on the bullet board, otherwise type 2. After having a comprehensive understanding of ICL surgery, will you get LASIK or ICL if you should like to undergo refractive surgeries? What is your rationale for picking laser eye surgeries or ICL? Leave your thoughts in the comment section below because I would love to know. Otherwise, pay attention to my future uploads, and I will talk to you soon.